this thing loose? Now it's working? Looks like it.
Yeah.
Where did I end them? What was I saying when it died? What slide was that?
Just tell them to stand by for just a sec.
Can you all stand by just for a second? We're trying to fix a problem that we have here.
You might plug in there.
It should be working now.
Yeah, so I think it was just
I'm not going to start over. Where did it go off from the beginning?
just about, it was right about here.
Okay, I guess we have to start over at polycystic ovarian syndrome. I hope you got the message earlier on that any questions need to be posted on the SIRM discussion board, haveababy.com, at the Las Vegas section, SIRM Las Vegas, and preferably on my website for IVF Authority. And all you do is go to ivfauthority.com and post questions at the comment section. All right, so let's start again, because obviously I got cut off. Something went wrong with the microphone, and thankfully Tom found it in time. So we're talking about polycystic ovarian syndrome. And as some of you may have heard, this is a condition associated with ovarian dysfunction, along with cardinal features of increased masculinization and typical features of polycystic ovarian morphology, which I'll show you in a moment. The pointers to polycystic ovarian syndrome, the typical features are that the woman tends to be overweight, high body mass, we call it the increased BMI. She tends to have absent or completely irregular menstruation. There's often and very commonly a history of infertility, difficulty in conceiving, because she's not ovulating with her irregular or absent menstrual periods. Excessive hair growth, which we call hirsutis, typically on the face and around the nipples and around the belly button. You'll notice if there's significant hair growth in those areas, it usually points towards hirsutis. A tendency to develop acne, not all women get this, but a tendency to develop acne. A family history of diabetes is very, very common in PCOS women. And then in the typical PCOS variety, there's a history of a male in the family with premature baldness. If not all of these criteria are always met, but these are the important criteria that point towards PCOS. Now, PCOS, polycystic ovarian syndrome, is the commonest metabolic abnormality in young women. Believe it or not, up to 10% of female patients of the reproductive age present with the problem I've just described. And it affects about 80% of women with irregular menstruation. So if a woman has irregular menstruation, there's about an 80% chance that will have a polycystic ovarian syndrome component to it. Here's a typical picture of ovaries with multiple cysts in them. These are subcapsular, that means they're under the surface of the ovaries. It's what they'll often look like from the outside. You see these little bluish domed cysts on the outer surface of the ovaries. And if you slice through the ovaries, then you will see in a pathological specimen these multiple cysts. Here is a picture that you often see on the ultrasound. This is only one section through the ovary, and here you can see that there's probably about 20 follicles in view in that section alone. I've seen a patient with polycystic ovaries who's had over 100 follicles present in both her ovaries, and frankly, in that patient, when we did IVF on her, we got about 87 eggs out of her. That sounds terrible, but you'll understand in a few moments that it's not always dangerous if you deal with it correctly, and it's often unavoidable, because women with polycystic ovarian syndrome typically have a tremendous exaggerated response to the use of injectable fertility drugs that we use in IVF and in certain forms of IUI, intrauterine insemination. It's almost like having a patch of gasoline in front of you. You're not going to get less of a blaze by putting a smaller flame to light it. Once it takes off, it just goes, and often even with very low dose stimulation, the woman still hyper responds. And of course that puts her at risk, as you'll hear later on, of developing severe ovarian hyperstimulation syndrome, which can be a life-endangering condition. This is a section through the ovaries I showed you earlier on, in that morbid section of the uterus and ovaries. This shows you big and small cysts all over the ovaries. Typically, polycystic ovarian syndrome, there are 3 varieties, and they're not distinct. Sometimes there's overlap, but this is very important to understand. The garden variety, the common one we see, that have all the features I mentioned, almost 80% of polycystic ovarian syndrome, comprises the woman that has a typical hypothalamic pituitary ovarian imbalance, leading to a pituitary gland producing an excessive amount of LH. And that in turn causes her ovaries to produce excessive amounts of male hormone, testosterone, that gives many of the masculinizing features, the increased hair growth and all the things I told you about earlier on. This is caused by a hypothalamic pituitary ovarian imbalance, and this is the typical one that runs in families. It's often genetically dominant, and it's the type of one where you often see in the family, as I told you, a male with premature balding and all the typical features of polycystic ovarian syndrome. So this is hypothalamic. Then there's one where the increased production of male hormones comes from the adrenal gland, and that's called adrenal polycystic ovarian syndrome. And then there's the third variety that occurs in women when there's a lot of pelvic congestion, commonly seen in advanced endometriosis, which thickens the outer capsule of the ovary and leads to, do I push this?
Yeah, if you want this to disappear.
Which occurs in advanced endometriosis. Now, whether the cause is hypothalamic, adrenal, or advanced endometriosis, it usually occurs because there's increased engorgement of the ovary. The capsule doesn't easily allow the egg to be ovulated out of it, and there's a trapping of these micro subcapsular follicles in the ovary, whether it be due to engorgement or congestion in the pelvis, as occurs with advanced endometriosis, or whether it be due to the increased adrenal production of male hormones such as testosterone, or whether it's due to the increased LH output by the hypothalamus and pituitary, which results in increased amounts of testosterone produced by the ovary itself. Typically in this variety, the characteristic thing we see is that there tends to be a much higher LH level in the woman's blood than FSH. Usually the FSH is higher than the LH, but with PCOS of hypothalamic pituitary origin, that relationship is inverted, and you end up with a much higher LH, often 2-to-1 against FSH. You don't see that typically in the adrenal cause, and you don't see that with advanced endometriosis causing congestion and thickening of the ovarian capsule with subcapsular cysts. The increased production of male hormones is seen both in the hypothalamic variety, or whether the testosterone or other male hormones such as androstenedione come from the adrenal gland. Doesn't matter where it comes from, you will see this hirsutis, acne, those kinds of features in both these varieties, but you don't usually see it in women with endometriosis-related subcapsular cyst formation. Then in women with hypothalamic pituitary ovarian versus adrenal, this is very important, dehydroepiandrosterone sulfate, that S at the end, that is added on in the adrenal gland. So when you see increased DHEAS levels, it means there's an adrenal involvement. This is very important because treatment of adrenal PCOS is completely different than hypothalamic. In the hypothalamic variety, you may get DHEA increased, but not DHEAS. So this is a marker of an adrenal cause. And then as far as signs and symptoms are concerned, there are ovulation dysfunction. The women tend to have ovulation dysfunction or absence of ovulation, most commonly in the hypothalamic variety. In the adrenal variety, you also see it, but it's of course much less common when these polycystic ovaries form because of capsular engorgement secondary to advanced endometriosis. So both in the adrenal cause and in the hypothalamic, and this one specifically, there's ovulation absence or dysfunction. The women tend to be much larger and have an increased BMI in the hypothalamic variety, but also somewhat in the adrenal variety, because sometimes in addition to the testosterone production, there's a more generalized release of cortisol and other adrenal hormones which increase body mass. But you don't usually see that in PCOS from women with advanced endometriosis. And as I said, hirsutis, which is due to the male hormone production, testosterone and androstenedione, is much more commonly seen in the hypothalamic and the adrenal varieties than in the advanced endometriosis variety. And acne, again, because of the increased production of testosterone and androstenedione, is more common in the hypothalamic and the adrenal varieties. Here's an important one. Because of the high incidence of a family history of diabetes and the predisposition to type 2 diabetes, women with hypothalamic pituitary ovarian type of PCOS tend to have elevated blood insulin levels. And that's very important to be looking for because it points more towards this problem and is far less likely in adrenal varieties or endometriosis, although I've seen some adrenal cases where there's a more generalized activation of also cortisol production, that there's also elevated insulin. But it's much more related to hypothalamic pituitary varieties. Now, how does this all work? And I don't want to go into this slide in detail. You remember I told you that and we're mainly talking here about the commonest variety, 80% of the time, the hypothalamic pituitary variety that I spoke about here. This is usually a genetically dominant disorder. And you usually find that in these women, their hypothalamus produces an increased amount of GnRH, gonadotropin releasing hormone, which causes increased LH production, and the LH affects the ovaries. There's an area in the ovary known as ovarian stroma. It is the connective tissue between the follicles that produces male hormones, and this becomes activated and typically overgrown in women with PCOS. We call this stromal hyperplasia, the stroma being the connective tissue, or hypothecosis. And there's an increased production because of the increased LH of testosterone and the androgens and androstenedione. This gets converted to estrogen, so the estrogen levels go up, and this triggers even more GnRH production, so you get this snowballing effect. And the insulin resistance also increases the problem with PCOS because of its effect on insulin-like growth factor. So we won't go into that in detail, but this is the way in which things develop to PCOS. So when we treat women with PCOS, let's first go to the one we use least nowadays, the old-fashioned traditional treatment of cutting a wedge of tissue out of the ovary to reduce the production of testosterone, or by drilling the little follicles with a little cautery and trying to do what we call ovarian drilling. This is universally or uniformly relatively unsuccessful in initiating pregnancies for a number of reasons. It doesn't get rid of the underlying problem, and while it doesn't decrease the amount of testosterone produced by the ovaries, and in some cases causes reduction in the symptoms and restoration of menstrual cyclicity, it also causes pelvic scarring that can block and damage the tubes. There are risks to doing this surgery that one wants to avoid, of infection and bleeding, and there's a low success rate. pregnancy rate is under 10%. So those people still doing surgical wedge resections and drilling, the former, namely surgical wedge resection, should really not be used unless you're trying to reduce symptomatology and you're not focusing on fertility at all. And ovarian drilling, in my opinion, is a useless procedure that really belongs in the history books, because while it may give you some benefit in the cycle or for a month or two after doing it, you quickly revert the woman back to where she started from. So then what about clomiphene and letrozole, but primarily clomiphene treatment to induce ovulation? That seems to be the first approach that most doctors take. Put the woman on clomiphene and hopefully she'll ovulate and get pregnant. That's not a bad approach when you are treating women with PCOS, because they don't tend to hyperstimulate as easily and develop severe risks of ovarian hyperstimulation syndrome as they do when you use gonadotropins, FSH-related products. But the success rates with this is not that high. It's about 10 to 15% per month of treatment. And there's another problem with clomiphene and letrozole. They increase the production of LH by the pituitary through stimulating more release of GnRH. You may remember me talking to you about that hormone produced by the hypothalamus. And this increased production of LH causes increased testosterone production. I'm not a big fan of clomiphene treatment, but it is a safe way to start off the process. 2 or 3 cycles. If it doesn't work, it's time to move on to the next approach, which is using gonadotropins. Now, you use gonadotropin treatment either in the form of when you're doing just regular stimulation to make the woman ovulate, or when you're going to do intrauterine insemination, or when you're going to do IVF. But it's important to understand that the pregnancy rate's higher with gonadotropins, but so is the risk of severe ovarian hyperstimulation syndrome. And it's very, very, very hard to control if you're doing IUIs. It's much easier to control the risk of ovarian hyperstimulation syndrome, which can be a life-endangering problem if you're doing IVF, by using things like coasting. Now, of course, this type of treatment with injectable fertility drugs is more expensive than is the use of clomiphene or letrozole, but it's much more effective. And I keep stressing to patients, always look at the cost per baby being born rather than the cost of a procedure. Now, IUI is a procedure that you can use, but if a woman hyperstimulates on fertility drugs doing IUI and you still trigger her with HCG, which triggers the process and gets it going, you are in big trouble. So if a woman tends to hyperstimulate with oodles of follicles and a high blood estradiol level, for God's sake, do not give the HCG if you're doing IUI. And if you're doing IVF, you can do something we call coasting. Let me try to put this in perspective. Women who ovulate on their own tend only to release a single egg from a single dominant follicle. Once that dominant follicle, the larger one, the one that's growing in advance of all the others, releases the egg in a natural, normal cycle, the others stop in their tracks. And so you don't tend to have multiple follicles being released. And that is why, and I've said this before, women who ovulate normally rarely get multiple births with fertility drugs. It's the women who don't ovulate regularly and normally, as is the case with PCOS, and women with other causes of ovulation failure due to hypothalamic causes, that tend to have lots of follicles reaching a large dominant size. And when you trigger them with HCG, all the eggs are released at once. And that causes the greater risk of multiple pregnancies. With Clomid, the risk of multiple pregnancy in a PCOS woman is under 10%, whereas the risk can be as high as 40% in women getting fertility drugs who either do not have IVF, where you can regulate the number of embryos you put back, or they end up having IUIs. So using intrauterine insemination and just regular ovulation induction for women with PCOS gives you a higher risk of OHSS, but also a multiple pregnancy risk, which is much higher because they release more eggs, and that's where the risk of multiple births is greater. With IVF, we can limit through coasting, and you'll hear about this later, the risk of multiple births. We can put back the risk of ovarian hyperstimulation syndrome, and we can reduce the multiple pregnancy rate by putting in 1 or 2 embryos at a time and no more. The problem with stimulating women with PCOS, be it for IVF or IUI, is that because the follicles develop so rapidly, and there's so many of them, and because of the risk of OHSS, the doctor is frightened that the estrogen level will go too high and the woman will get into trouble with severe hyperstimulation syndrome, and the doctor often erroneously triggers the HCG, gives the HCG shot early in order to avoid the follicles getting too large and the problem from propagating. And in the process, in doing that, the eggs are not fully developed by the time they're forced to go through meiosis and mature. And as a consequence, we end up with eggs that have an abnormal chromosomal makeup, being much more common in women with polycystic ovarian syndrome. It's one of the problems. You get a lot of eggs, but a lot of them aren't normal. You can reduce that problem of having to trigger the woman too early with HCG by doing coasting. And we'll be talking about that when I speak about ovarian hyperstimulation syndrome. Please remember that at least 75% of women with PCOS will fulfill criteria of insulin resistance. They'll have high insulin levels. And if you treat the woman, I'll go back, using metformin when she's got high insulin, and in my opinion, there is no basis for using metformin routinely on all PCOS women, especially if they're not of the hypothalamic pituitary variety, because it's possible, in my opinion, that it can even do harm to egg quality. But if you use metformin when there is a situation of a high insulin output by testing the blood insulin levels or doing a 2-hour glucose tolerance test and you find it to be abnormal, then using metformin will, in a significant number of cases, slowly and progressively reduce the output of male hormone testosterone, and some women with PCOS will even revert to normal regular menstruation and ovulation on metformin therapy. It's certainly worth using in women with hypothalamic pituitary PCOS if they have high insulin levels, but in my opinion it's best not to use it. It should be selectively used. It's selectively effective in those women where it's needed, but not in everybody. So if we now look at metformin treatment for PCOS, it increases sensitivity to insulin, which is reduced in certain types of PCOS. It decreases insulin levels and it decreases male hormone production, as I mentioned earlier. So let's move on now to ovarian hyperstimulation syndrome, which has a marriage with PCOS, because most of the severe ovarian hyperstimulation, the life-endangering variety that we see, is associated with PCOS patients. It can also occur in very young women, and you'll see the type of women who are at risk in a moment, and women who've got other forms of ovulation absence or dysfunction. By definition, ovarian hyperstimulation syndrome is a rare but a potentially life-endangering complication that occurs after ovarian stimulation with gonadotropins. It can occur with clomiphene and letrozole, but is very less likely to do so with those medication. It takes a few days after you trigger with HCG or LH for the signs of OHSS to develop, which are characterized by multiple follicle cysts developing and severe ovarian enlargement, and then changes in the blood vasculature of the pelvis that will result in fluid shifting from the blood into the third space. That means from the blood into the area surrounding the blood vessels and into the pelvis, into the abdominal cavity, where it can present as ascites or collection of fluid, or into the lungs, into the pulmonary cavity, not the lungs itself, but surrounding the lungs, as pericardial effusion, as pleural effusions, or around the heart even as pericardial effusion. And as this fluid shifts across, the actual amount of fluid in the blood vessels decreases. The blood becomes thicker, and oftentimes this causes reduced blood flow in the through the small blood vessels, which become clogged, to vital organs such as the kidneys, such as the liver, and the bowel. And this can result in major problems that cause women to go into shock and develop blood coagulation problems that can put them at very, very high risk, and they can get organ failure as a consequence of this. Here's a picture of a woman with hyperstimulation syndrome. You see large follicles, many of them all over the show. You see large follicles and small ones all over the show, and this type of situation looks like almost like a honeycomb. And these kinds of women are at tremendous risk of developing ovarian hyperstimulation that can put their lives and their health in danger. So the first point about this condition is that it occurs after induction of ovulation, usually using injectable fertility drugs like Menopur, Follistim, Gonalef, Purigon, and that sort of thing. It occurs, but it only occurs after the HCG shot is given. Up to that point, these follicles can grow. There can be even 100 of them, and the woman will not be at risk until she ovulates or with LH, or she gets an HCG shot. And that will then cause changes in the cells that line the inside of these follicles. And they will start to produce a substance known as VEGF, vascular endothelial growth factor. This substance gets into the blood supply surrounding the ovaries and causes the blood vessels to become more porous and leak the fluid that I described out of the blood supply into the surrounding tissues. And this causes therefore increased permeability of the capillaries and blood vessels, and so you get a massive fluid shift, so that the amount of blood in the blood vessels themselves decreases, and it goes into a third space, into the abdominal cavity, into the thoracic cavity, and even around the heart, the pericardial cavity. And it can go in the lungs, it can go into the interstitial tissue, causing an often terminal condition called adult respiratory distress syndrome. When these women with this condition get so sick that they start developing adult respiratory distress syndrome, where we see a lung whiteout, they can't absorb the oxygen, they can't exchange gases, they often do not survive, and they're very difficult to treat when they get to that point. These type of women, when they get to this pre-terminal state, often have what we call disseminated intravascular coagulation. Their blood is clotting in all the organs, and various toxins are released that make this problem of vascular permeability and the blood not clotting anymore, which we call a consumption coagulopathy, much more severe, placing the woman's life in danger. And as I said, this decreased blood flow through the blood vessels causes reduction of blood flow through the various organs, the kidneys, the liver, the lungs. One of the early signs of ovarian hyperstimulation becoming severe and dangerous is that the urine output decreases. There's a dramatic decrease in urine output because of reduced blood perfusion brought about by the sludging effect in the small capillaries and blood vessels that feed the kidney glomeruli. And it also happens in the liver, so that you often find in the more severe cases that liver enzymes increase. And because of this and the coagulation disorder that I mentioned often occurs in the more severe variety, platelet counts drop and the woman's blood fibrinogen level drops, and she also gets an increase in certain fibrin degradation products, fibrin split products, and fibrin monomers, all indicative of a coagulation disorder occurring. So these women also tend to have, because the blood is so thick, a much higher blood concentration, so their hematocrit level goes up, as does the hemoglobin level. And they develop thromboembolic events. They can shoot clots to the brain. They can shoot clots to any of the organs. And as I said, disseminated intravascular coagulation is a very advanced stage of this disease. And this condition is completely avoidable if you just don't give the HCG trigger if the woman's at risk. So who is then at risk? Again, women with PCOS are the cardinal risk. Very young women whose ovaries are very sensitive, and women who've got absent or dysfunctional ovulation with irregular or absent menstruation that is not related to PCOS. So there are really 4 varieties of PCOS. The one is a mild variety, and most women who stimulate for IVF will tend to veer towards mild distension of the abdomen with some bloating, enlargement of the ovaries. That's mild OHSS. In honesty, it's hard to imagine a properly stimulated woman undergoing IVF without having a mild degree of this syndrome developing. Now, the moderate variety, now you start getting abdominal pain, nausea and vomiting, and some fluid in the abdominal cavity as noticed by ultrasound examination. And the ovaries enlarge to about 8 to 12 centimeters in size. Now we move on to the severe variety. Here you can actually, by examining the abdomen and doing what we call percussion of the abdominal wall and testing for shifting dullness, you'll be able to detect the fluid in the belly by examining the abdomen of the woman. Sometimes you'll even detect it clinically in the chest by hydrothorax, seeing a hydrothorax which is easily picked up by X-ray. The urine output is very much reduced. It's under 400 cc's per 24 hours. The blood hematocrit is elevated above 45. It's normally sitting around 35 or so, or 35 to 40. And the amount of albumin and protein in the blood goes down because a lot of this is passed out of the blood with the fluid into the third space. And the ovaries are now enlarged to over 12 centimeters. Now, in the critical variety, the very severe one, now there's typically a tense abdomen with clear evidence of fluid distension, and fluid often in the thoracic cavity and even around the heart. And a hematocrit, because of the hemoconcentration that I've described to you here, is now over 55. The white blood cell count is very elevated because of a steroid or cortisol-like effect and because of concentration of the blood in the blood vessels, and it's over 25,000, and the urine output is very, very diminished or completely absent. When it's absent, we call it anuria. And then there's the risk of thromboembolism, shooting clots, and the disseminated intravascular coagulation I told you about. And then the ARDS, the adult respiratory distress syndrome, is an endpoint in this critical severe variety. This is the variety that costs lives, and it can be prevented, and this one can also be prevented. And probably the moderate variety can also be prevented by taking the appropriate steps. So what do we do to treat this condition? You know, I'm going to go through this because it's so important for you to understand that you reduce the exposure by using low dose of gonadotropins, but the injectable fertility drugs, but that does not prevent the condition completely. It will reduce the risk if you use very low dose. The higher the dose, the more you're going to cause exacerbation of follicle growth. Second, don't use HCG after the woman has had her egg retrieval. Do not give HCG. Some people think that women with PCOS are candidates for a process called in vitro maturation of oocytes, where you remove the eggs without significant stimulation. This has been a very disappointing field as far as I'm concerned. I think the results with in vitro maturation are poor, and I don't think this is a way that people should go to try to avoid OHSS. And then you can use metformin, as I said, by using it preventatively before you come to the cycle. There's no point giving metformin just as you're going into a cycle. It needs several months to take effect. Then the secondary strategies to prevent it is, some people have suggested reducing the dosage of HCG. Instead of giving the regular 10,000 units, give 5,000 units. In my opinion, this is a very poor alternative. It might reduce the risk of OHSS, but it also doesn't provide enough HCG to drive the eggs into proper maturational division or meiosis, and should not be done, in my opinion. So you're reducing the dose of HCG, I think, is a poor way of salvaging both the woman's safety and getting good eggs. You've got to give 10,000 units of HCG. Now, 10,000 units of HCG is equal to 500 micrograms of Ovidrel, or Ovitrol in other countries. And so when you use 250 micrograms of Ovitrol, you're in effect giving the equivalent of 5,000 units of HCG. That's why I think that dose of Ovitrol in any patient is too little. I think you need to double the dose, and you need to use HCG 10,000 units in all women that you trigger with HCG, even if they have PCOS. The solution to the problem is to prevent that getting to the point that you have a problem going forward, not to reduce the dosage of HCG and compromise egg quality. One of the other things you can do is, when you get to the fertilization of the eggs and the embryos, you can freeze them all. Today, using vitrification, which is a 60,000 times faster freezing method than older methods, you can keep embryos safely. And as I told you, the problem that fans the flame is HCG. So if you take all the embryos and avoid the woman getting pregnant, she's not going to produce her own HCG, and you'll make the risk to the woman of overstimulation limited, usually to no more than 10 to 14 days after the initial HCG trigger. So if you think you're in a situation where you may develop severe or critical OHSS, for God's sake, do not, if you take the eggs out and make embryos, do not allow her to get pregnant. Freeze all the embryos, vitrify them as blastocysts, and hold them for future dispensation in a frozen embryo transfer cycle. And then you can, of course, cancel the cycle completely and not give the HCG at all. And of course, that will alleviate the problem. No matter how many follicles she produces, she's not going to be at risk if you don't trigger with HCG. Then the other alternative is you can use GnRH agonist, which is believed and has been shown to reduce the risk of OHSS. So you can basically, rather than triggering with HCG, give the woman a shot of Lupron or Buserelin, and that will cause her LH to surge. And there's a lot of evidence that using this approach to triggering ovulation is safer for women with PCOS. I don't like it because you can't always predict how much LH is going to be produced. I still prefer HCG, and I think the problem is completely avoided of even having to consider using GnRH to trigger if you do coasting, which is in my opinion, the treatment of choice to avoid critical OHSS or severe OHSS from developing. And I'm going to explain to you how we do that later on. But basically what we do is when we see the woman is developing follicles, before they get to the very large size, when they're all around 14 millimeters, or at least half of them are 14 millimeters, you stop giving the injection of gonadotropins, and you continue with Lupron. You give them Lupron daily. That prevents LH from being released from the pituitary, and you continue the Lupron, and you'll see the estrogen level going up, and sometimes it'll go out of sight so high. But then you wait for it to come down. And when it drops down below the level of 2,500 picograms per milliliter, and only then, even if it drops down to 1,000 picograms, doesn't matter, that's when you trigger with HCG. And I give 10,000 HCG in such cases, and have seen women with over 50 follicles show no sign of hyperstimulation. It takes a few days longer. The patient has to wait, but you get the eggs to develop better. If you start, the critical thing with coasting is it's got to be started and timed accurately. It has to begin when the follicles are around 14 to 16 millimeters, not when they're already 18 millimeters, because by then if you start coasting, yes, you'll get her out of danger, but the eggs will become post-mature, the follicles become cystic, and you've got lousy eggs and a poor outcome. Most of the people that talk about poor results with prolonged coasting are cases where the coasting is initiated too late, when the follicles are too large. So you've got to watch the woman, watch the follicles, and when the estradiol goes above 2,500 and there are more than 25 follicles, that woman should be coasted, and you should watch the estradiol daily. As I say, it'll usually go up and then it'll come down. If you start the coasting before they've reached 14 millimeters, then you will find that many of them just tank down and you lose the follicles and you lose the cycles. So you need at least 50% of the follicles of greater than 14 millimeters before you start the coast, and then you continue coasting, measuring the estradiol every day until the level goes up, and you watch it come down to below 2,500. By that time, the follicles are all going to be around the ideal size of 18 to 22 millimeters, and that's when you trigger with 10,000 units of HCG, or if you really want to, and I don't, you use GnRH agonists to trigger with. Other strategies that are used, I don't want to go into the details. Some doctors have tried giving women antagonists when they start showing signs of hyperstimulating, giving them cetratide or orgalutron, and they claim an improved outcome. I'm skeptical about that approach. Others use intravenous albumin. This was first reported by a guy called Ricardo Ash, who's probably recognized through notoriety many years ago from UC Irvine, who introduced the use of albumin to try to cause the fluid to go more slowly out of the blood vessels by increasing the osmotic pressure inside the blood vessels, and so limit the amount of fluid that leaves the blood vessels into the third space. Others use dopamine agonists, and others give steroids. I don't believe these work very well, but these have been tried and some people are reporting success. So what do? I don't want to go into details here, but we have to be very careful on how we treat these women. Women with mild or moderate OHSS can easily be treated as outpatients. Women with severe OHSS can also be treated as outpatients. But when you start seeing it's going to the critical level and the woman's urinary output is diminishing dramatically and her hematocrit goes over 55, and she starts developing signs and symptoms of multi-organ failure, or there's fluid in the chest and she's got a tense abdominal cavity full of fluid, ascites, these women are best treated in the hospital. And you've got to treat their pain. The way you best treat that is to reduce the tension in the abdomen, and that's done by draining the fluid out of the abdomen as often as is needed. I have drained fluid from the pelvis through transvaginal needle aspiration up to 5, 6, 7, and even 8 liters of fluid from women when I've been called in to deal with critical cases of OHSS. I can tell you that they get immediate relief. It takes the pressure off the kidneys and off the main blood vessels, and blood flow improves as well. Often the urinary output improves as well. Draining the fluid out of the belly reduces pain by reducing distension. But sometimes the pain can be due to the ovaries being so large that they start to twist. We call it ovarian torsion. When that happens, the woman starts developing typical signs and symptoms of vomiting, diarrhea, and terrible symptoms of that are associated with a parasympathetic effect related to ovarian torsion. She gets very sick and develops symptoms of acute peritoneal irritation. This is a surgical emergency. I've never seen a case that I've treated that's ever needed it, but some women need surgery, and often in such cases, they lose one or both ovaries in the process. Draining the fluid around the lungs is also worthwhile considering. It's called thoracentesis. And of course, you have to maintain the woman's electrolyte balance as best you can. If you want to try intravenous albumin, sometimes some doctors do, and you need to try that's the people that believe that you can reduce VEGF, the vascular endothelial growth factor that causes leakage through the blood vessels, recommend using dopamine agonists or steroids for that. If there's a blood coagulation disorder, that's very serious and very advanced. And if there's renal failure, sometimes dialysis needs to be used, and you have to treat the adult respiratory distress syndrome by bringing in a specialist, a pulmonologist, to help you. But when you get to that level, the patient needs to be in hospital with a multidisciplinary approach to a treatment. I'm not going to go into details about this, but this is the typical long pituitary downregulation protocol that we used, with agonist-antagonist conversion. But when you use prolonged coasting, what you do is the woman is stimulated, and when she's got more than 25 follicles and 50% are over 14 millimeters and the estradiol's over 2500, at that point you stop giving the FSH, the Follistim and the Gonal-F and the Menopur, and you just continue the agonist, the Lupron injections daily, and you watch her. It can take 5 days or longer, and the estradiol will go up, and when it comes down to below 2500, you stop the coasting, I trigger with HCG and do the egg retrieval 36 hours later. If I'm still concerned that she might be hyperstimulating, I'll freeze all the embryos, the blastocysts, and she will self-limit, and within 10 days or 14 days the problem is gone. That's as far as I'm going to go here. I can only add one last thing, and it's this. It is that if the woman gets a full-blown severe ovarian hyperstimulation syndrome, it'll continue to get worse all the way through to the 6th to the 8th week of pregnancy, or even longer. But usually by about 70 days, there's a sudden shift when the dominance shifts from the ovary to the placenta for hormonal output. The woman suddenly gets better, and overnight, I have a patient that I had some years back who had such distension she could hardly breathe. In those days, we weren't doing paracentesis, reducing the fluid. This takes us back to the early 90s. This woman, I was so worried about her. I moved into hospital, had a bed in her room and slept in the room. And one night I said to her, I'm going home. I'll be back the next morning to see you. I'm going home to see my family, and I'll come back the next morning. And when I came back, her room was empty, and I got the fright of my life. I thought, what the hell happened to this woman? I went to the nurse and said, where is she? She said, knock on the bathroom door. She was in the bathroom. She'd been there all night, and when she walked out, she had passed all the fluid that had been in the belly, everything reversed, and she was ready to go home. So that's how quickly it reverts after 8 or 9 weeks. So we'll start with the questions and answers now. I hope that was helpful to you. I know it's a lot of information, but I will try my best to answer them. And starting here?
Down here.
Okay. Kat asks, since I wasn't able to view it, I see something about ovarian drilling, and this had been done without my consent. Catherine, I pointed out earlier that it's an old-fashioned, shouldn't be used, in my opinion, any longer method of trying to cause these subcapsular cysts to reduce and to have the woman kick back to ovulation. I don't think it works. I think it's very short-lived if it does, and sometimes causes complications because it's got to be done via laparoscopy. And I don't use it at all, and I don't advise it to be used. Brenner writes, I've been told I have thin PCOS. I'm not insulin resistant. Does this mean I probably fall under the adrenal category? Not necessarily, Brenner. Some women with typical hypothalamic pituitary PCOS still can be thin. You don't even have to have hirsutis, increased hair growth, or anything. There's a broad spectrum, but you should be tested to have your FSH, LH, testosterone, androstenedione, and DHEAS done to see if it may be of adrenal origin. Because if it is of adrenal origin, the treatment is to use steroids in low dose to lower the adrenal component. And many women on steroids with adrenal PCOS improve just on steroid treatment alone. Sharon writes, I popped in to say hello. Our son turns 7 next week. Thank you so much, Sharon. I appreciate that. The next one is Missy Lampkins. I've had 4 failed IUIs with Clomid. Is IVF my only chance of pregnancy? That's a different topic, but if you failed IUI 4 times with Clomid, yes, I would say IVF is needed. Missy, give me a call at 800-780-7437. That is, write that number down, those of you that haven't got it, 1-800-780-7437, and you can reach Tina, and set up a Skype consultation to discuss this with me, because I really believe that I can help you work through that and decide whether IVF may be the best way to go. Very often women who fail IUI repeatedly often have an underlying missed tubal problem with slight adhesions or endometriosis, and the latter is more common. Tara, how much is an IUI? I really can't answer that question because I don't know. It's a couple of $100, Tara. So you can call up and speak to any of the clinics and speak to the administrator there, and they'll be able to tell you the exact fees for IUI. Simone writes, I have an underactive thyroid and PCOS. Is a paleo lifestyle diet recommended? If your thyroid's underactive, Simone and anybody else listening, the first evidence is that your TSH level will be elevated, usually above 3, and if you do, you should be tested for anti-thyroid antibodies. And these antibodies are in 50% of cases associated with natural killer cell activation, and this can cause an immunologic implantation dysfunction, and you will not get pregnant no matter what you do easily until the problem's dealt with. So if you've got an underactive thyroid, have yourself tested for anti-thyroid antibodies like thyroglobulin and microsomal antibodies, and have your blood tested for natural killer cell activation by the K562 test. Contact ReproSource, ReproSource in Boston. They have a website, reprosource.com, and contact them and tell them I told you to call them for these immune tests to be done. Or call my office and speak to Tina and let's discuss it. Let's have a Skype consultation. Again, the number is 800-780-7437. Hope writes, I've had 5 failed IVF transfers, 3 fresh and 2 frozen. In total, 14 embryo transfers out of all 1 pregnancy which ended in miscarriage at 8 weeks. I recently found that I have a high insulin resistance and I'm overweight. And you have PCOS. Well, Hope, the most likely explanation for this is that the embryos were not chromosomally normal, and it may well be, and I'm not saying it is, that the timing of the trigger of HCG was not optimal, and that the eggs hadn't developed ideally, and that you ended up with embryos that were abnormal. Or maybe you've got an underlying problem that was missed, such as an immunologic implantation dysfunction, or you have a thin lining. And this is important to remember. I didn't mention it earlier on. Women with PCOS who have high androgens, testosterone, androstenedione, have a suppression of the ability of their uterine lining to respond to estrogen. And unless you get that the male hormone levels down and under control, they'll tend to have a thin lining of under 8 millimeters and not easily conceive because the lining's too thin. Sometimes there's an unrelated immunologic problem, but very often it's because of the type of protocol of stimulation used and the timing of the HCG trigger. That is where coasting comes in. So, Hope, I urge you, give a call to Tina at 800-780-7437 and let's talk. Brenna writes, I've had a failed IVF cycle a few months ago. I had 27 eggs that fertilized. I had several excellent and several good quality eggs on day 3. By day 5, all but 2 eggs quit growing. Please remember this, Brenna. Please remember this. Embryos that don't make it to the blastocyst stage are chromosomally abnormal. They tend to have an irregular chromosomal makeup. If an embryo makes it to blastocyst, it doesn't mean it's normal, but it's more likely to be. So those that embryos that don't make it, you can assume were abnormal. And my suspicion is that even though the eggs looked good and they fertilized and were okay by day 3, they were really abnormal because of the timing of the trigger of HCG. That's the suspicion I have. I'm not saying that women with PCOS don't inherently sometimes have a lot of abnormal eggs, because they do. But the biggest and the only preventable cause is the right protocol of stimulation with a proper timing of HCG. So I think your problem is pretty clear. It's probably related to the stimulation protocol. Again, call Tina and arrange for us to talk. You said we transferred a blastocyst and an early blastocyst, but neither took. If you got that many eggs, 27, and only one blastocyst, the likelihood is that that blastocyst was also not normal. Rebecca Arnold asks, is it harmful if you don't have your period often? It's not harmful to you, but it is harmful in terms of the fact that it often, in 80% of cases, points to an underlying PCOS. And women with PCOS are at greater risk in their later lives of developing problems such as uterine cancer and ovarian cancer and possibly even breast cancer. So you've got to be watched very carefully if you've got PCOS. Have regular checkups with your doctor every year and make sure that you're under control. Christian Gudino writes, oh, you were answering a question. Okay. The next one is Malia. What type of diet do you recommend for insulin resistance? That's not my expertise, but you can definitely get hold of a nutritionist who can advise you what you should do. I know that it's darn difficult for women with PCOS to keep their weight under control. You've got to get your insulin resistance under control to get your weight under control. You've got to eat certain vitamins that are helpful and maybe use metformin, and you need to get onto a diet that will bring down your insulin level to help further, and that's all I can advise. Now Rebecca writes, no. Where am I now? Is it harmful for to do HCG diet shots? No, it's not harmful to take HCG if your ovaries haven't been stimulated. The risk comes once you're stimulated and then you use HCG. Although I'm really personally not a big believer in HCG diets, I don't see that that would be a problem. Malia writes, does metformin or anything other, I've lost it, or anything other than lasers help with hirsutism? Yes, that's a very, very good question. The formation of hirsutism is due to conversion of testosterone in the peripheral cells of your skin to dihydrotestosterone. And dihydrotestosterone, that conversion can be blocked by blocking an enzyme known as reductase. And there's a drug that is out there known as cyproterone acetate, CYPROTERONE, CYPROTERONE acetate. Not obtainable in America, but obtainable in Canada. The only reason it's not available in America is because they can't sell enough of it to make it economically viable, which doesn't make it a bad alternative. It's one of the best alternatives for treating hirsutism because it blocks that reductase enzyme. And then there's another agent called aldactone, which is also known as spironolactone, which also works often in combination with cyproterone acetate. It gives a very good result on hirsutis. And I'd be very happy to talk to you about this if you call and set up a time with Tina. Sometimes wedge resection of the ovary by cutting out a big chunk of ovary that reduces testosterone production will also improve hirsutis. I'm not advocating it, and it's certainly not advocated if you're trying to have a baby. But if all your concern is relating to your symptoms and signs, then that is sometimes an option. The next question is, will this be on YouTube? Yes, it will be on. You can watch it on the same site, right, Tom? Right here, you can watch this presentation on the same site by tomorrow. Please invite any friends that you know that have this problem, because it's very common. 10% of young women with metabolic problems have PCOS. Some don't even know it. So please, if you have friends that need to see this video, and I think they should, then really point them to it. Missy writes that we have an appointment on Tuesday at St. Louis. You're going to meet a phenomenal doctor there, a great person. Her name is Melina Dayal. She knows this stuff. And if you talk to her, she's going to be extremely helpful. And she's one of my favorite people. So when you speak to her, give her my love. Rebecca writes, I can't hear or see. Did he answer my period question? Yes, I think I did, Rebecca. But if not, post it again. And if I've answered it, I won't repeat it. Maria says, yes, Maria, I look forward to speaking with you. Anybody who wants to have a Skype consultation with me for an hour, call 800-780-7437. Ask for Tina tomorrow, because I'm very booked out and I don't want you to have to wait too long. And let her book that Skype consult. You may have to wait till next month or maybe even a few weeks longer, but it's worthwhile doing, because I think for many of you I can provide you some good input. We are now done with all the questions. And before I end, let me just say thank you to every one of you for attending. This was a heavy one to do for me and for you. It's a lot of information, and I'm sure I just touched the surface. But it'll give you an idea that there is something out there that you can do. And I would be delighted to be of help to you. And if any of you have got any comments that you'd like to make regarding this, the value, if you've had any, out of this webinar, we'd appreciate your comments. And I'd also like you to, if you can, go to our Facebook and post any comments there. Thank you so much. I look forward to talking to any or all of you. Have a wonderful evening.